Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode.
This week on Plenary Session, I'm joined by Dr. Chris Booth. Chris Booth is friend of the show. He's one of the few people who's actually hosted this show. He knows what it's like to be in the hot seat. And he's joining us from Canada via Zoom.
If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD, MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com.
All right, I'm back in Plenary Session with Dr. Chris Booth, Professor of Medicine at Queen's University in Kingston, Ontario, Canada. Dr. Booth is a card-carrying GI and GU oncologist at Global Health Authority and a friend of the show. He's done seminal work, of course, on many topics, but those include progression-free survival and the endpoints of randomized controlled trials. Dr. Booth, it's a pleasure to have you back.
Good afternoon, Vinay. Thanks for having me. It's wonderful to be back.
Do you have COVID up there in Canada?
A little bit of it. Not as much as you guys do. It's a cold weather variant, though, but we do have some of it.
I see. Our goal is to see what it does when it's allowed to run its course. I think at least some people think that's one of the goals in this country. I don't know.
Yeah, I know. I must admit the Canadians have looked south of the border with much trepidation. And I mean, there was jokes circulating about if there's going to be a wall built, perhaps at one point it should be the northern wall to keep COVID out. But in any case, we look forward to the day when our borders open and we can visit our American friends.
I look forward to that day too, Chris. It's been a long year here south of the border. So I wanted to start by talking a little bit about, how do you view oncology in the time of COVID? I mean, people aren't interested in our work anymore. They're not interested in the endpoints of clinical studies. The journal market, I've been joking, but I think there's a lot of truth in it. Right now it's rock bottom. I mean, the number of open slots for non-COVID articles is low. They've accepted a ton of COVID articles, and there's a glut of COVID articles that are seeking a home. So I mean, it's not a great time to be a researcher, COVID or non-COVID, really.
Yeah, I agree. And I mean, I think, I got involved in some COVID work, over the last 6 months as well. And I must admit that, our group and others, and many people have commented on this, that the quality of the methodologic rigor of much of this work is very, very poor. And obviously that's something I hope we can learn from in the coming years. So I agree. I think cancer has been, certainly publishing cancer research has become more difficult. There's been important work done about the implications of COVID and delivering cancer care. But I guess, in some ways, I see what I hope is a silver lining for cancer research, which is I think that COVID in all elements of our life, both our personal life and our professional life, I think has allowed people to kind of focus on what actually really matters and, ask some hard questions about, what treatments we actually should be bringing people in for and what ones we shouldn't. And I hope that this serves as a wake-up call that, as oncologists, as scientists, as cancer researchers, we kind of have one kick at the can.
Right.
And maybe COVID will be a bit of a wake-up call that I think, as I joked with, I think it was Aaron Goodman I joked with when we were talking about another topic. I said, I think my threshold for bullshit has dropped in COVID, and I think a lot of other people's has too. And I hope that forces our community to become more accountable with the treatments that we propose and the studies that we design going forward. We really need to become, I think, held accountable by society to make sure that we do high impact work.
That's well said. I think that's one of the silver linings is that particularly early on, every decision we were making was focusing on the most high yield things we do in oncology and trying to minimize those things we do in oncology that sometimes we do just to go through the motions. So we tried to minimize palliative chemotherapy that we thought was beyond what was really in somebody's best interest. We tried to minimize visits and blood draws and unnecessary PET scans if we didn't really need it. And that was good. I mean, I think that allowed us to focus. The question will be, of course, when COVID ends, are we going to slip back into our old ways, or are we going to take away some lessons and practice high-value care?
Yeah, I totally agree. And I mean, my kind of introductory COVID experience, this was actually in March. I remember it was over March break. We were supposed to go skiing in Quebec with the kids, and that got canceled for obvious reasons. And my colleagues, Tim Hanna, who's a radiation oncologist and health services researcher, and Gerald Evans, who's a senior infectious disease doc at Queen's, we very quickly wrote a priority setting framework. It was published in Nature Reviews Clinical Oncology, where we kind of, at a conceptual level outlined the treatments that if the health system went into real crisis and we had to rank the cancer treatments that we were going to deliver when the health system was at its breaking point, and which treatments could probably be safely or appropriately deferred, it led to a pretty honest discussion about what matters and what doesn't.
Right.
And it was, I think quite eye-opening, especially for a non-cancer physician, to be involved, to see how much of this stuff that we consider standard we could pretty easily put to the side if a health system was pushed to its limits.
Right.
And to be honest, the patients probably wouldn't suffer, and ironically, they might be better off.
Right.
So there was this framework, and I mean, as we wrote it, we kind of joked, this should be a framework that we use all the time. And the stuff that's at the bottom of the priority list in the middle of a health system crisis, we should probably ask ourselves, should we ever be giving it? And so I think that's kind of an example of going forward. I do worry that we'll slip back into our old ways. I guess one thing I think that has not been really discussed is, the serious economic reckoning that's going to come in the healthcare system in the coming decade as we struggle to pay for the economic implications of COVID.
Right.
And, I'm not an economist by any means, but there are going to be massive, massive pressures in all elements of the education system, the healthcare system, as we begin to service the debt that was required to sustain economies through COVID. And I do wonder if this incredible budget pressure is actually going to force healthcare systems to finally take value-based care very seriously.
Yeah, I think that is a good way to think about it. Probably the way different nations react will be very different. In our nation, I worry that one of the immediate consequences is that people are looking at the red that they suffered in first quarter of 2020, and they want to make that black. And so what they're going to do is ramp up the marginal testing, downstream interventions, the low-value surgeries. I'm worried they're going to do that. But the other thing I wanted to mention to you that I thought maybe you'll find funny is that a number of these publications on COVID-19, I respect the groups for doing them, I guess, but I don't think they tell us anything remarkable. I mean, so a number of things are like risk factors for cancer patients with COVID-19, and they were kind of what you'd expect: being older, having progressive disease, receiving the need to receive active drugs. That's not so good if you also get COVID-19. And being in remission, being younger, being cured of your disease, that's better. And so I thought to myself that, I guess it's laudable to verify those things. On the other hand, there's a number of publications that are all saying the same thing, and they're not saying anything that's particularly surprising to a doctor. And yet, of course, the journals had an appetite for that very briefly. I think now that appetite is gone. But I don't know. Any thoughts on these kinds of publications?
No, I agree. And I mean, I think, we probably cut everyone some slack in the first few months when there was a lot of fear and uncertainty. I think that, one could potentially consider doing COVID type work for the next 5, 10, 20 years. And when anyone approaches me now about doing some kind of retrospective cohort study about patterns of care and outcomes, I must admit my gut instinct is, first of all, I think we're all going to be tired of COVID, and hopefully in a couple of years, it'll just be a distant memory.
Right.
But I also think it's time to move on. I mean, at some point, COVID will disappear, and we're still going to be left with the pressing public health issues that we've always had, and maybe we can use some of the lessons we've learned from COVID to make real contributions to reducing some of those public health problems.
That's well said. That's why you're always the diplomat, Chris Booth, the diplomat. Okay, let's talk about your new paper. It's coming out this week in JAMA Oncology. This is a really interesting article, a comparison of randomized controlled trials over, I think, a 3-year period of time. And there's thousands, 2,500 randomized controlled trials. Booth, you know how to work the trainees. You work them real hard, make them read all these studies. And I guess I'd say that you're comparing randomized controlled trials that are both run in high-income countries or who have corresponding authors in high-income countries to randomized controlled trials run in low or middle-income countries and those with corresponding authors in low and middle-income countries. And there's just so many interesting things that shake out, from the type of endpoint how often they're positive, how often they meet ESMO meaningful benefit criteria, where they're published, whether or not there's some bias there. I wonder, where do you want to jump in on this? Where do you want to start on?
Yeah, let me. So I'll talk with the genesis, because sometimes I think
that's always
the interesting parts of projects, where do these come from? So this project originated over a cup of tea in Mumbai, followed by probably gin and tonic, with my dear friends Professor Pramesh from the Tata Memorial Hospital and Richard Sullivan from King's College London. And the three of us work very closely in the Indian context and also more broadly in global oncology. And the discussion was that the mainstream cancer research ecosystem appears to have lost touch with reality. And reality, we mean by that both what matters to patients in high-income countries, but also what happens in the rest of the world outside Western Europe, North America, and a handful of other very wealthy countries. And so we asked ourselves, is there a way that we could undertake a study to explore the extent to which randomized controlled trials are being done globally? How do they align with the burden of cancer? And is there a way to illustrate perhaps important differences between studies run in rich countries versus low resource settings, and how we might learn from each other? So that was kind of the genesis of it. And then we put together this team, kind of a diverse backgrounds, different disciplines from different parts of the world. And we said, well, let's do an overview of all all cancer randomized trials published over 3 years.
Mm-hmm.
We looked at only anti-cancer therapy. So it was really systemic therapy, radiotherapy, and surgery. Anything that was related to prevention or supportive care, we did not include, because the numbers, the initial literature search was in the thousands. And we ended up with 694 published randomized trials. And we did not restrict it to high impact journals, because we wanted to find everything. And so we had a number of questions we were asking. First is, how does the design of trials differ across settings? What can we learn broadly from the global RCT ecosystem?
Right.
How do the results vary between different economic settings? And then what is the output? Where do these things go? How are they published? And how are they implemented into practice? So that was kind of the backstory. As far as kind of some of the key findings, so not surprisingly, the vast majority of randomized trials, was 92%, originate from high-income countries. They tend to study systemic therapy, so actually only 13% of RCTs are testing novel approaches to radiotherapy or surgery.
Interesting.
And actually, if you drill down even further and look at what types of systemic therapies, 60%, so basically 2/3 of every clinical trial in the world, is testing systemic therapy in the palliative context. And so as far as relieving human suffering and improving outcomes of cancer, there's probably a disconnect there between what we're aiming and what we're actually studying. I guess some of the other kind of relevant, high-level findings was that the proportion of randomized trials across different cancers did not match the global burden of cancer. So, not surprisingly, breast cancer was far overrepresented in randomized trials.
Interesting.
When you look at the proportion of global deaths due to breast cancer and the proportion of randomized trials. And then we saw the converse for diseases of, cancers of poverty, cervical cancer, liver cancer, gastroesophageal cancer, and even pancreas cancer were far underrepresented when it came to global RCTs. So those were some of the initial kind of big picture findings from the overall global trials portfolio.
Yeah, those are so many interesting things. Yeah, I noted that a number of malignancies were underrepresented: pancreas, GI, esophagus was underrepresented.
Yeah.
I mean, cervix. Ironically, those are diseases that, of course, disproportionately affect low and middle income nations, and maybe less to lesser degree in high income nations. The other interesting thing that jumped out at me was, you point out that the trials that are run in low and middle income nations often have an author that's from a high income nation, right? So there's only a tiny fraction that are run by people in low and middle income nations. The classic is multinational randomized trial that has a US centric author, and they're recruiting in some low and middle income countries. You want to talk about that a second? I mean, I thought it was something like 40% of the accrual was in a low and middle income country, but only 13% of the authors were from that.
Yeah, it's a great point. So let me let's get to that. Why don't I tell you? We'll go over with some of the highlights of what we found. The differences between trials that were led by authors in high-income countries versus those from LMICs. So first of all, who's funding this?
Yes.
Okay, so we found that 70% of all RCTs in cancer are funded by industry. And this varies based on where the trial's coming from. So in high-income countries, 73% are funded by industry, whereas only 41% of studies from LMICs are funded by industry. What do the trials look like? Again, some of these things weren't surprising, but it's good to have data to back it up. Trials in high-income countries are powered to detect smaller differences. The sample size is more than twofold larger.
Wow.
Having said that, they are less likely to be positive. So, about 67% of RCTs and LMICs actually met their primary endpoint, and 45% of RCTs in high-income countries met their primary endpoint. Moreover, when you look at the effect size, the magnitude of benefit of these positive trials, the hazard ratio in LMICs was far larger. So the hazard ratio was, the median hazard ratio was 0.62 for positive trials in LMICs and 0.84 in positive trials from HICs. That's a pretty substantial difference. So the effect size varied considerably. I want to get into the impact factor issue and some of the kind of bigger, broader policy issues in a moment.
Sure.
But I guess as far as endpoints, only 31% of all clinical trials have overall survival as the primary endpoint. So we're now chasing surrogate endpoints, or I should actually rephrase that. As Elizabeth Eisenhower recently corrected me, we should use the term putative surrogate endpoints.
Oh, because they're not proven always. That's a good point.
Correct. So I think that's a really good point. We've our language has given, has artificially elevated these putative surrogate endpoints. But anyhow, so about a third are progression-free survival, and about a quarter are DFS, EFS, relapse-free survival. So those are some of the kind of the bigger findings. I guess, why don't I pause there, because there's kind of some things we can unpack and talk about, but then we're going to get to the issue about where these things are published and the idea about what you talked about, which I call research parachutism.
That's a good word for it. Okay. So, I mean, what you're saying is that there's an explosion of clinical trials. They're almost all systemic drugs. They're almost all, a lot of them are industry funded, and they're chasing surrogate endpoints. And I think some of the interesting things you're pointing out are, we really don't, we don't test as radiotherapy as much as we ought to as the investigational agent. Of course, if there's a radiotherapy trial, both arms have radiotherapy. No, just kidding. They do some randomized trials, but we're not asking the tough questions for radiotherapy, for surgery, and for adjuvant therapy. That's one of the points you made. And I guess your argument would be that if you really want to make a dent in global cancer outcomes, as much as we love drugs used in non-curative settings, they tend to have median survivals on the order of, 2-3 months. If we were to test better ways to cure people with radiotherapy, surgery, or adjuvant chemotherapy or adjuvant therapy, we might make a bigger dent. Is that part of your argument?
Yeah, absolutely. I think as, medical oncologists and, cancer physicians, we have to have some humility and recognize that, chemotherapy plays a really important role and increases long-term survival and cure rates in an important way for many cancers. It improves outcomes in the palliative context for some cancers in a very, very substantial way. But at the end of the day, most chemotherapy, at least in solid tumors, does not cure the cancer. What provides cure for our patients is radiotherapy or surgery. And we've neglected those when it comes to the global research ecosystem. And I think if we want to make a big dent in global mortality, we need to reconsider and recalibrate how we allocate resources across the research space. Now, one of the challenges, of course, is that the funding now is dominated by the pharmaceutical industry. So I'm sure our surgical colleagues would like to complete trials, but without access to funding, it makes it that much more difficult.
Fascinating. And I think that's right. Okay, why don't we get into the research parachutism? Get into the where people are who get the credit and where people are who are enrolling the patients issue.
Yeah. So I think this is really interesting, actually really important. So, just to drive home one of the key points from some of the data we've just talked about, that we can learn a lot from our colleagues leading trials in LMICs. They they don't have the luxury of designing frivolous trials to detect improvements in survival of a few days or a few weeks.
Right.
They are faced with, massive clinical workloads, incredible resource constraints, and just huge infrastructure hurdles that we could never conceptualize. So when they design a clinical trial, they want to make sure it's impactful. So they're designing smaller, more efficient RCTs that are powered to detect larger benefits. And I think that we should learn, and this is part of the bidirectional learning of global health, right? Traditionally, it only flowed in one direction. At least that was the mantra in global health. And we can actually, I think we need to correct some of our mistakes and learn from our colleagues that are designing these important trials in LMICs. There's obviously a shared partnership there, and we'll maybe touch on that in a moment. But I think one of the really important take-home policy messages is where these papers end up being published. And so let's talk about a couple complicated issues. I guess one is the concept of what I call research parachutism. And this is, you've alluded to this many times when you dissect a multinational clinical trial in which treatments are given in low resource settings where standard of care or access to testing and imaging might be very different than it is in the United States, Canada, or in Europe. And so the idea of conducting a clinical trial in a country in which you are not planning to really offer that treatment, if it's successful, is problematic for two reasons. It's problematic because if the trial is being delivered in a context where standard of care does not match the standard of care in the environment in which you wish to roll out that treatment, then the patients who are being offered this treatment in the United States and Sweden, Canada, and the UK, they're suffering because they're being offered treatments based on data that does not actually apply to them. And on the converse, we're also, I think it's totally inappropriate to be doing clinical trials in countries that have limited resource and offering these expensive, toxic, unproven therapies with no hope that the patients and future patients in those systems will ever have access to that. And that's what I call research parachutism, which is going in and, it's the traditional colonial model of global health, going in, taking data and leaving. And the society and the patients in which the research was done don't necessarily benefit. And so I think that's an unspoken problem that still exists in global oncology and global health. I think there's movements towards mitigating that, but I think it's something that needs to be out in the open. And, we'll talk about now the impact factor prejudice. And I think this is one of the reasons that the editors at JAMA Oncology, they recognize there is a major problem. And I have to applaud them for publishing this paper because it makes the medical research ecosystem and the journals, it doesn't make us look very good. Right. And so just to get to that, so where do these things end up? So we used impact factor as a very crude marker of the profile that was given to these clinical trials. And we found a huge discordance in impact factor. So the median impact factor for a randomized trial from a high-income country is 21. So that's pretty high. Right. You and I occasionally publish in journals with impact factors of 21. But we've been in journals with impact factors at 2.1 before as well.
2.1 is my home. That's my home.
so impact factors are 21 for high-income countries and 7 for LMICs, okay? And these are RCTs that have been done in very, very challenging circumstances, and they're addressing really important topics. So there's one important finding. However, you could say, well, what drives the impact factor? Well, there's the publication bias with positive trials being more likely to be in high impact journals. So when we stratified for that and we looked at positive clinical trials, we saw it actually gets even bigger. So a positive RCT from a high income country published in journals with an impact factor of 25. For LMICs, the impact factor was 9. And for negative clinical trials, again, we see HICs published impact factor 18, LMICs published an impact factor of 5. So the real kicker is that positive clinical trials from LMICs are still published in journals well below negative trials in HICs. So I think this is a publication prejudice problem that needs to be recognized. It's probably complicated. There's a number of factors driving that, but I think just by putting some data to it and drawing attention to it, I think it might hold the medical research community perhaps accountable to consider how this can be mitigated going forward.
So many interesting things there. I guess I first want to talk about the first part. What you were saying was some of these trials. I mean, they're really like a pebble in my shoe. They bother me, and they bother me in the sense that they are multinational studies. that are really run with with one or two purposes in mind. One purpose, getting US FDA approval, because we're willing to pay any amount of money for the drugs, and we pay the most money, and so they want to get our approval in our country. And then they want to get, Canada, although you all are tougher, because they can get approval in Health Canada, but they can't get coverage in every province unless they're willing to play ball. But they're happy to play ball with you, give you guys some concession, in part because if they get your oncologist giving their drugs, it's better sell to get everyone, all the players from Western industrialized nations giving the same drugs so that we can say this is the standard of care. The same thing in Europe. They want EMA approval, but not as bad as FDA because they're probably not making as much cumulative revenue there. And then they got to play the game country by country approval. So then they run this trial, and they run it in a global setting. They're accruing, as you point out, something like 40% of patients on these trials. The control arm is often something that we wouldn't give in Canada or the US or Great Britain. We wouldn't feel comfortable giving that control arm. It's not our typical standard of care. Or after the patients progress, they don't get standard of care like we would give. They don't get second-line therapies. They don't have options to have, let's say you're moving a checkpoint inhibitor up. The control arm is previously getting a checkpoint inhibitor second line. They're not giving it in this trial because it's run globally. Such a trial, the irony is twofold. One, it doesn't help people in those countries because they know damn well when the trial is positive, they're going to price the drug so high, it is essentially unaffordable to anyone in that country. So all the people in the community there, they will never have a path to these drugs because they can never afford these drugs. In fact, proof of that is the control arm is already not what we're doing in Western industrialized nations. It's often 1 step, 2 steps, 3 steps behind because they can't even afford those drugs, let alone the novel drug. The next thing is it doesn't help people in the US or Canada or Great Britain because it's telling us the new drug is better than something we're not even doing anyway, or the new drug is good when you don't have post-protocol care. So I feel like it's this great double exploitation. It's exploiting the people in those countries directly because they're not going to get access, and it's exploiting the financial system of our country, really. It's exploiting the taxpayer wealth because it's paying for a lot of lucrative products that we don't really know add health. It's really exploiting two worlds, ironically, and yet it's omnipresent.
It is, and I think, I think we as as researchers, but also as practicing oncologists, our community, I think, needs to hold these trials accountable. And I think talking about these issues, writing about them. I think most people in the research world and the clinical world, they want to do the right thing. Right. And I think somehow we've abdicated that responsibility to another entity, and I think we need to take that back. And I think by talking about it is, probably the first step.
Yeah, and I think so. I think that's one important theme that of course you and I are going to agree on. We've talked about it a lot before. The second thing that I think worth talking a little bit about is, you put it really nicely that people in low and middle income countries, clinicians, they're very busy. For them to do the trial without the pharmaceutical industry support, they're gonna want to pick a study that is really impactful, and you see that in all the metrics. There may be some publication bias, but the studies in low and middle income countries are more likely to be positive. That's tainted by maybe there's some studies that you don't see at all because they're the bottom of the iceberg. Yeah. The next thing is, though, when they are positive, they're more likely to meet higher thresholds on ESMO. And you looked at the power calculation, so they're more likely to be powered for bigger deltas. That's in part resource constraints because they can't just randomize 10,000 people looking for, a 0.2 day difference in DFS like we like to do. So they have to really ask meaningful benefits. But that, as you point out nicely, we can learn from that. Some of our trials are overpowered, powered to find statistically significant but clinically meaningless differences. I think about that recent study from Tata about women who have metastatic breast cancer, whether or not we should still remove the local mass in the breast in case they were diagnosed with de novo metastatic. And this is something that there have been so many patients in retrospective observational studies from the US, the UK, where we look to see, does breast removal in metastatic disease improve outcomes? And those retrospective studies are generally favorable, that it does improve outcomes. Of course, there's the bias that if the patient is really sick, you're not going to refer them to surgery. And if they're less sick, you are. So it could be the sort of confounding by indication and not the surgery itself. And in fact, when they did it in Tata and they randomized people, that's what they found. They find no benefit from doing this. But that is a hugely impactful study that was run in a low and middle income country and published, actually one of the few ones that was published in a really good journal. And your point is that there are many such studies, and that the entire process of review, it's so easy for reviewers to say this is a study from India or from China and denigrate it and not think highly of it. But you're pointing out that translates directly into the average impact factor of these trials, 7 versus 21. I think you're making a very interesting case for equity and how we think of each other as researchers.
Yeah, I think it's just something that, I'm sure our colleagues and investigators and LMICs have been aware of this for years. And right. I think that, to have some data to at least advocate for change and, drawing awareness to this is going to be the way forward, because I think that we have much more to gain and learn from our colleagues who have been forced to be creative in the way they deliver care. Their models of care are different. And I think that there's a lot that we can learn from low resource settings. And by not giving their research the profile or the platform it deserves, it is hurting all of us. And so I think there's a lot that on the upside of fixing this apparent problem.
So it's a fascinating paper. I mean, if we could step back and look at it, and you have a number of policy suggestions at the end. But I think, I don't know. I guess I want to make a plug for what you're doing. Like, you're looking at the landscape of published randomized controlled trials from high impact, from high income and low and middle income nations. You learn a lot from a good descriptive study. I think sometimes you learn a lot more than you learn when you pretend you did causality and you didn't really do causality, which is really sort of the sine qua non of being a modern researcher, is to say, I have found a new causal observation, here it is. And I actually am never drawn to that kind of research. In fact, you're one of the few people who will recognize I almost never do that kind of causal research because I'm not smart enough to find causes and effects that people haven't found. But I like the kind of research you did, because it's really just looking from a mountaintop at what we see. And you see so much already. You see, I think, sort of unfairness in how likely publications are refereed. You also see different places setting different agendas. And I think you also see, the heavy hand of the for-profit industry, which leaves the biggest impression of the hand is left in the high-income nations. But it affects the whole world. But the corresponding author is, of course, a high-income nation corresponding author. So I wonder if you might talk about, your policy recommendations or what it's like to do such a very large, obviously, a lot of work. You read thousands of articles.
So thanks, Vinay. Yeah, a couple of kind of comments in response to that. The first thing is, I guess, just to acknowledge the research team. So, this idea, was generated in Mumbai years ago, but a lot of the heavy lifting was done by an internal medicine resident, Connor Wells at Queen's, who is moving to Vancouver to do a medical oncology fellowship at the BC Cancer Agency next year. Him and Shubham Sharma. Shubham is a medical student at Queen's, reviewed all the trials. Joey Del Padro was involved, helping with the ESMO scoring and some of the quality checking. And then we had a whole team of kind of content experts. Wilma Hopman, our biostatistical wizard, Nazi Kamad and Vishal Gawali from Queen's, Ajay Agarwal and Richard Sullivan from King's College London, Debbie Mukherjee from American University Beirut in Lebanon. And so it was actually quite a fun group to work with. We've got a number of kind of secondary papers coming from this, because as you alluded to, these are big projects with a huge amount of data that can provide these high level insights. And I think, I've done several of these projects now. My first one was the original evolution of the randomized trial. And so I guess just to give your listeners a sneak preview, as you well know, as a co-author, we have the third iteration of the evolution of the randomized trial in the works right now, and hopefully we'll see that in publication soon with some very provocative findings. But some of these projects, as I like to joke, these are like grade 8 science level projects, right? The science here is actually fairly simple, right? You read the methods, people can understand it. You don't need complex methodology and fancy statistics to get important findings from this type of research. And I think it does give us an idea, where have we come from and where are we going, and how can we maybe alter the direction of the ship? And so I enjoy doing these, high-level overviews, but it certainly takes a lot of work. So I did want to acknowledge, especially Connor and Shubham for all of their work. So as far as policy implications, I guess the first thing is just to kind of recognize that there's this funding paradox that if we really want to alleviate global suffering, we need to think about ways to fund cancer research that does not suit the agenda of the pharmaceutical industry. We need to think about how to fund research for radiotherapy and surgery. And most importantly, we need probably philanthropic organizations and governments to step up and fund impactful research, both in HICs, but most importantly in LMICs. I think that, I have a privilege of teaching every year as faculty at the CREDO methodologic workshop run by Dr. Priya Ranganathan from Tata Memorial Hospital. And this is, I think, one of the jewels of the National Cancer Grid. It's a week-long, very intensive research methodology program. And this is something that is going to change the way that research is done in LMICs. This is starting in India, but they're starting to build very rich South-South partnerships with colleagues in Sub-Saharan Africa. And I wouldn't be surprised in a few years if we begin to see similar courses. This is kind of like the Vail and FLIMS courses of the LMIC context. And it's a really remarkable program. So I think there's infrastructure barriers. There are barriers in clinical workload that prevent clinical research. There's funding. There's barriers in training too. At least in the Indian cancer system, it's starting to change, but much of the clinical training is focused on looking after patients. And so learning critical appraisal, research methodology, this is now starting to move in the right direction, but there's certainly room for improvement there. And perhaps that's where there can be natural partnerships between centers that have some of the methodologic training, but we can also learn about some of the innovative approaches to models of care that are used in these very busy low resource settings. I guess kind of the final issues relate to this publication prejudice, and I think JAMA Oncology, by publishing this, is going to draw attention to it. I think editorial boards and editors can perhaps consider how they might handle pieces coming from LMICs. We haven't done this yet, but I have an idea with a fellow to take a look at, the composition of editorial boards, and are they representing the global population? And perhaps that's one way of beginning to shift the needle. And I guess just to kind of emphasize that, the true joy of kind of global health and global oncology are these very rich friendships and collaborative partnerships and the bi-directional learning. There's actually a lot that we can learn from each other, and it's actually a lot of fun. And so just by doing this type of work, we hope to kind of inspire future collaborations that can help move things forward for cancer patients globally.
Well, that's hard to top. You hit so many excellent points, Dr. Booth. So many excellent points. Okay, I agree with everything you said. I think you really did a nice job of taking us through all the different things that would make one think about. I really like this workshop you run in India. The Credo, is that right? Credo is the title.
Yeah.
And I think that's the right model. And I think you point out nicely how there are lessons that can be learned, I think, bidirectionally in this research. Okay, since I have you, I'm going to ask you a different question, because
Sure.
We can come back to this in a second, but it's hard to get a hold of you, Dr. Booth. You've dodged me for months. Okay, so I stole something you told me. I stole it, and I wrote it down, and I put it in something I'm trying to publish any day now, so maybe it'll be out by the time this is here. And it was, because it's just such a gem, but it was, we were talking about something, I don't know, I think we're talking about something like, a theme that I've been interested in, which is like, how do you make the most of the time you have? And we all acknowledge we don't have infinite time. When you're young, you think you do, and that's a mistake in life. I wish I could go back in time. You don't. You really have to choose. And the challenge isn't keeping yourself busy as you get older. The challenge is finding a way to not be so damn busy. There's always going to be something you could work on. But as you, I think, go along, you realize that a lot of what you do, you feel like you didn't really connect with anybody. You sang a song and no one heard it. You played a piano tune and no one was there to listen. Or it was something that somebody else did a little bit better, or was duplicative or redundant. But sometimes you do feel like, boy, that struck a chord. That really did something. Anyway, so I was telling you about this, and then you wrote back to me, a few other people, and you said that every few years what you do is you take your CV and you get a copy in your hand, and you get a bunch of highlighters, and you highlight everything 3 colors. Okay, green, this was impactful. This was something that if it weren't for Chris Booth doing this, it wouldn't have been done. And, people wouldn't be talking about it. People wouldn't be doing this or that downstream of it. Yellow, this was definitely supportive work. It definitely helped this field think more clearly about X, Y, or Z. We helped. We were a part of the team. Yellow. Red, this wasn't really impactful. Like, we did a good job. We didn't screw anything up. We're not coming up with a fairy tale or anything. We're not photoshopping Western blots, which is I hear it's in vogue. I don't know. You and I we don't know what a Western blot is. We don't know. We never work on that stuff. But it didn't really resonate. And then you told me that you actually, I thought it was such a great exercise. We should do something like that. And I'm going to give you the microphone in a second. So like, you should obviously focus on the green and do less red. And I was telling, and I had like been doing something similar, but I hadn't really articulated it. And my thing was, I put things in buckets, like thematic buckets. Like, we work on surrogate endpoints, low value medical practices, cancer drug pricing, and financial conflict of interest. And I don't think I actually told you this, but a year and a half, like maybe 6 months ago, a year, or when I was leaving Oregon, I looked at those buckets and I really felt like, and you're gonna kill me because I know you and I still work on some projects in this vein, but I personally have not done I haven't taken the lead on these projects. But the financial conflict of interest is the bucket that struck a chord with me, in the sense that I felt like we have been hitting this issue so nicely, and the papers that hopefully you and I get out soon, they hit it super nicely. Like, they show things that you didn't think about or you didn't consider. But the problem I struggle with in that field is that nothing will change these people's minds. Nothing will change their mind. They're so just wedded to what they're doing, and I don't know what to say. If I can prove that it's bad and that it's prevalent and it does this and that we're being paid, pittance for what we're doing for the field, and but they don't change their mind, Chris. And so I got so frustrated. I was like, okay, we're done. Whatever, we're no more projects on financial conflict of interest until we can regroup and build and something new. I don't know, think of something. But then, you came to me with 3 awesome ideas, and obviously I got roped in. But but it's not to say it's not important. I still think it's important. I just, okay, anyway. So I wonder if you'll talk about this. This is really important for trainees. How do you think about where your time is spent? Do you get frustrated? Do you redirect energies? You've had more years in this field and you've made some pivots. I wonder if you talk about that.
Yeah, those are great points, Vinay. So I can't remember exactly which mentor it was, but one of my mentors sent me, probably Dr. Tannick, but sent me a piece by David Sackett, and I think I've sent it to you. I've sent it to kind of people that I work closely with and people that I mentor. The paper is called The Determinants of Success for a Clinician Investigator, Clinician Scientist. And it might be worth, sending out in your social media for junior trainees to read. And one of the things that Dr. Sackett recommended was doing this periodic priority list. And so I had that in the back of my mind. And I guess it was about 4 or 5 years ago, I was on a long flight home from India, actually. And I was faced with this kind of career decision. And this led to the pivot, which I think you're alluding to, which is I had a really, really busy population-based outcomes program focusing on quality of care, disparities in outcome in Ontario. And it was really, really hopping. It was a big, dynamic, exciting program with a lot of output and took a lot of energy and time and effort, and which was a lot of fun. I learned a lot. But I also had this growing program in collaborative work with colleagues in India. And in the backstory, I always had this interest in, clinical trial endpoints and cancer policy and magnitude of benefit and things. And I was actually, I had 4 young kids at the time, and I was struggling to balance it all. And I was feeling like I had to make some decisions about what was going to be the most impactful in my field, and also what was going to be the most rewarding and gratifying for me. And that's where I did the highlighting exercise. And it's funny that you've taken to this, because I guess it's a similar, perhaps it's a slightly more artistic version than your buckets, right? So I color coded things. And I went through my CV. I just use published papers as a metric for things. It could be anything. It could be active projects, whatever. Right. And, I must admit there was more red on that list than I wanted. And as you said, there's nothing wrong with the red because we learn things in doing it. Often it was to help a trainee who needed a project, or it was something that, I learned a new methodology, but there was more red there than I wanted. And I wanted to really focus on things that I thought would be yellow and green. And so I looked at, what was the nature of the red projects, and it became pretty apparent where I could make a bigger impact and contribution. And so that was really insightful at helping me to align my interests and my time. And actually that led to this pretty big career decision. I had a full-time analyst doing the population-based work in Ontario. We were having probably about 30 papers a year from this very rich database of linked treatment records, registries, kind of similar to a SEER Medicare type program, but we had all the pathology reports too. But it was an overwhelming, it's like a fire hose of data. And I decided to turn the hose down. So I dropped down to a 0.5 analyst, and that created a huge amount of space to think and to do things in other fields. And then eventually I've kind of, now I don't have my own analyst doing that. I work in kind of a senior capacity where I have junior faculty who have their own analysts, and I help and mentor them and work with them. So I still continue to do this and I enjoy it, but it's allowed me to kind of go back to some of this magnitude of benefit, clinical trial endpoint work, but also really ramp up the global cancer policy work. And I actually updated the highlighting exercise, I guess, in the last few months. Maybe it was actually our conversation. It triggered the memory. And I was pleased to see, actually, there's a bit more yellow and green than there was. There's still some red there, but I mean, I can always maximize some red, but it's actually made a difference. So it's not level 1 evidence. It's not a randomized intervention, but so I don't know if it's called, but the color coding has changed. And at least I kind of have a sense that, where my time's going and where I can make the big, what I think is the biggest impact.
It's so interesting to me. I mean, when you say it that way, I guess I definitely agree with everything you're saying. And I guess the only other additional things that come to my mind is I don't know. I was trying to pick my own brain, and I was like, why am I drawn to certain topics and not other topics? Like, what is it that draws me in? And I guess I must say it's like, I would call it like rationality failures. It's like the places in medicine where like otherwise reasonable people are saying things that aren't reasonable. And like those include like, oh, this new study that has like clear methodologic flaws, like should be the reason why we prescribe everyone a $12,000 a month medicine. Like you and I co-wrote that stuff on Polo Trial. Like, okay, that strikes me as a rationality failure because we're like, okay, the people who say this, they're very smart people. They went to good schools. Like they're not fooling anybody, but they're saying something that's like clearly like doesn't make any sense at all. And hopefully someday, God willing, we get the Profound trial out there. Oh, by the way, this is a bone to pick with you. Now I can pick it in front of the listeners. Booth always tells me, you listeners, listen here. We do these discussions of journal clubs, and Chris always makes the point that, and it's, Chris is right, that as good as podcasting is and as good as Twitter is, it has a short half-life. It's ephemeral. It's doomed. It's not going to last forever. You need to write it in a way that it is indexed and it's forever accessible. So somebody looking at this trial 10 years from now will know that there were these caveats and limitations, or at least somebody said it. Anyway, I agree with Chris, and I tried to do it. But, it's not easy to publish. And
I know. We have this beautiful paper, and it's been turfed everywhere. I know. It's we need just a Prasad and Booth journal, and maybe we'll just kind of put it in long format on your Twitter feed. But yeah, I agree. I mean, I think it's really important that these monologues and these critiques that you and others do are written down and become part of the scientific record. And I hope, I would imagine that there's some forward-thinking journal editor out there that would be interested in this, and maybe there's a partnership that you could make. But I think that is really important. But you're right. We've got one that I think we're both, banging our head against the wall that's been kicking around for a while that really needs a home. And these are important things. I guess the other comments I'll make in response is your decision to give up work and financial conflict of interest. I can tell you there's like a massive party at the pharmaceutical industry. This podcast, you're like, we won. Prasad back down. That's good. And the other thing is the reason why I think you're drawn to all these topics and projects is, I describe you as you're the philosopher oncologist, right? It's your philosophy training. And maybe I'm the interpretive dance oncologist. I don't know. But anyhow, or the karaoke oncologist. But
well, that's kind of you, but that's not the description I read online. Okay. By the way, I tweeted out something like, is there any journal that will host these pair podcasts, like critiques of articles? And I don't know, it led to a bunch of discussions. But one of the journals wanted us to pay a couple $1,000s for every one of these. They're killing me. I mean, there's no grant that's going to give you money to be critical of a for-profit study. It's not very fundable for the open source fees. What it is. Okay. Yeah, I guess I'm drawn to those things. I think what you're saying is super important. In the sense that you want your work to be impactful. And I think a mistake people run is that they just want the work to be the thing to get them to the next level. And if you do that, you're actually like, you'll make yourself like, you won't enjoy it. I think like if you don't feel like, it's not only that the work is impactful. It's like, were it not for like we needed to be the people to do this. Like this couldn't have been done by other people. There weren't those people doing it. Like it required Chris Booth, like it's both the work is important and like it's the right use of Chris Booth. Anyway, there's like some Japanese term and I'm not going to pronounce it because I mispronounce it, but it's apparently like finding purpose at work means you find something that you enjoy doing, you're good at doing it, society benefits from you doing it, and society pays you to do it. And like when those four things overlap, that's like your purpose in life. And I was thinking about it because in this commentary, I argue that like, we do often find like what we like to do in medicine, be it research or clinical care, it's all over the place. We do often find what we're good at. Like we're really good at sniffing that out and doing more of it. I think sometimes on the research side, we get pulled to do things we're not good at because we think that that's what we should be chasing. But you're very good about that because you're not somebody who, you can talk about if you want, you're not somebody who's like just chasing titles. You actually are trying to craft a job that fulfills your purpose. So you're not just trying to get promotions or anything like that. Okay, then what society benefits from, that's something that's, I think, a core mission that both you and I think that's probably why we're such good friends, like draws us together. And then the last thing is like what you get paid for. And I guess we're lucky that we're like researchers who get paid to do this. But I do think that that's something that we can improve. Like there are lots of things in medicine. Actually, it's probably better in Canada than it is in this country. But in this country, obviously we pay people for doing special procedures and not for thinking about patients. And that leads to all these kind of errors. And so in the article, I say that like we should actually like reform the payment and we should think about these things explicitly. Anyway, what does that make you think about? Yeah.
No, I agree. I mean, I think it's kind of aligning interests to, for greater societal good. But also I think there's a lot of personal satisfaction that will come from contributing in the ways that the Japanese philosophy outline is actually, quite powerful. And I think that that's probably the holy grail to kind of a fulfilling, meaningful career is finding alignment of those four things. So I think there's probably a lot that we can learn from that.
Chris Booth, our time is run short. So how come you dodge this podcast so much? That's my question.
Well, I wanted to have something exciting to talk about.
You always have something exciting. You listen to podcasts? The whole goal of a podcast, people don't want to hear you saying anything exciting. They just want to hear you saying random, mundane things. That's what they crave. I don't know why. That's what people crave. And even when I listen, that's what I crave sometimes.
Yeah, no, I know. Well, I guess, this is probably my third visit to plenary session. And as you said, I put this on the top of my CV. It's the only title I care about. But, I hosted a plenary session once. And
you got lost in the woods. If people go back, they'll hear us getting lost,
exactly.
Right?
Yeah, I've been lost in Oregon. And then I got to host you in Kingston. And lots of fun. But I certainly always enjoy listening to this and a great fan of it. And I think it's actually, serving a really important purpose. So yes, I will not dodge your invitations in the future. I know we have several common projects coming out that will be another opportunity to discuss. But,
yes.
Thanks for having me, Vinay.
It's a pleasure. It's a pleasure, Chris. And hopefully we get to meet again. And besides plenary session, do you listen to other podcasts? Obviously,
no, you're the only one.
Shut up.
Yeah, you're the only one.
Oh, I'll give you a list. Soon plenary session will be off when I give you a list of stuff that I listen to. I'm like, it'll push out plenary session, but it's the golden age of podcasts.
Yeah, no, I know. I find, when do you listen to them? When you ride your bike?
I would say riding my bike, running. I listen when I run, driving, commuting, and actually sometimes in my office when I do that, like, this is maybe, like some epic tasks are very sort of rote. And they're not like cognitive tasks. They're like clicking this stuff, clicking that stuff. So that's one sometimes I listen to. And then sometimes I like to lay in bed. This is going to sound odd, but like instead of reading a book at night, sometimes I just listen instead. What about you? Do you read books?
I read lots of books, a lot of books. That's what I do every night. And I don't listen to podcasts that much because I just don't have as much time to listen. I used to, listen, because, if I'm riding my bike or driving, I do listen to plenary session. This is a funny story. I was listening to it for a while when I was running, and then my wife said, "What are you listening to? It's making you run too slow." So Now if I listen to anything, I listen to good old rock and roll because Prasad's monologues were making me jog and not run.
Oh, wow.
So I backed off a little bit. But,
happy to take that.
No, I do enjoy it. I should tell listeners should know that our podcast host is wearing a lovely sweatshirt right now. Why don't you tell us a little bit what you're wearing, Vinay?
This is a fine vintage 2019 garment from Canada. It's just a classic Roots hoodie. You know, when I was there, I made a beeline for that Roots store, and I got it's just a good sweatshirt. It's just a good company, and all around good Canadian. Tim Hortons and Roots are like you can't go wrong.
Yeah, that's good. Yeah,
well,
future sponsors of Plenary Session. There you go.
You know, I guess I'd say if Roots came to me and they said, you want to be a sponsor, we'll take our first sponsor with Roots. But someone tell me it's not going to happen. Well, Chris Booth, it's a pleasure to talk to you.
Yeah, thanks, Vinay.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.